In 2011, the Illinois Department of Human Services completed a scheduled compliance review of a state-operated residential care facility in Sangamon County. The review reported no critical deficiencies. Staffing levels met state requirements. Medical documentation was current. Within the same calendar year, 6 residents from that facility died. Each death was attributed to natural causes or existing medical conditions. Each was reviewed independently. The records show no missed procedures and no policy violations. They do not explain why the same observations appear repeatedly across different files, or why those observations never change the course of care. This examination is based on administrative records, internal reviews, and documented procedures. It focuses on outcomes produced through compliance rather than misconduct. What follows relies on what was recorded, what was reviewed, and what was allowed to continue. The facility functioned under a standardized residential care model approved by the state. Residents were adults diagnosed with cognitive or developmental impairments. All placements were long-term. Daily operations followed a fixed schedule. Morning wellness checks occurred at 6:30 a.m. Medication administration followed physician orders entered into the central charting system. Meals were delivered according to dietary classifications. Evening checks were completed before shift change. Care staff rotated on 12-hour shifts. Each shift maintained observation logs. Supervisors reviewed logs at the end of each day. Medical staff conducted scheduled rounds twice weekly. Health concerns were categorized using a 3-tier system. Minor observations were logged for monitoring. Moderate concerns required nurse review. Urgent issues required physician notification. Most entries fell into the first category. Language in the logs remained consistent. Resident resting. Behavior within baseline. No visible signs of distress. Audits focused on documentation accuracy and completeness. Facilities were evaluated on consistency rather than outcomes. The system treated stability as evidence of proper care. The first irregularity appears in a night shift log, dated March 3, 2011. The entry reads, "Resident awake for extended period. No agitation observed." The note was signed and closed. No follow-up was required. Similar entries appear in the following weeks. Different residents, different staff members, extended wakefulness, repeated night activity, baseline behavior unchanged. None of the entries triggered escalation. Under policy, sleep disruption without physical distress did not meet reporting thresholds. In April, 1 resident missed 2 scheduled meals. The absence was logged. The resident resumed eating the following day. The incident was categorized as resolved. In May, medication compliance notes began to include delayed ingestion. The delays were documented. Doses were eventually taken. No physician notification was required. Each anomaly was minor. Each fit within acceptable variance. Together, they formed a pattern that was not evaluated as a pattern. By early summer, internal logs showed an increase in minor health-related notes. No single entry indicated decline. No individual case met intervention criteria. The system recorded activity. It did not interpret accumulation. The first death occurred on June 18, 2011. The death certificate listed natural causes. The case file was closed. At the time, no connection was made to the preceding records. After the first death, routine operations continued without modification. Shift schedules remained unchanged. Medication rounds followed the same timing. Observation logs continued to use standardized phrasing. In July 2011, a second resident was hospitalized overnight for dehydration. The admission note recorded no acute findings. The resident returned to the facility the next morning. The incident was logged as a temporary medical event. No follow-up protocol was triggered. During the same month, 3 residents were noted to have reduced verbal responsiveness. During evening checks, each entry was documented separately. Each concluded with baseline variability. Supervisory review notes indicate acknowledgement. No escalation is recorded. In August, dietary logs show repeated partial meal consumption across multiple residents. Percentages were recorded. Trends were not analyzed. Policy required action only if refusal persisted for 72 hours. In each case, intake resumed before that threshold. Night shift reports continued to reference extended wakefulness. Day shift reports continued to note resident resting. The language did not change. The second death occurred on August 29, 2011. The resident was found unresponsive during a morning check. Emergency services were contacted. Resuscitation was not attempted due to documented medical directives. The cause of death was listed as complications related to an existing condition. The case file shows completed documentation and supervisory sign-off. No deviation from procedure is noted. By early September, internal logs contained a higher volume of minor health observations than in previous quarters. This was not flagged. The facility's reporting system evaluated entries individually. It did not assess cumulative deviation. A nurse noted in a weekly summary that multiple residents appear less engaged during routine interactions. The note was recorded under general observations. It did not require response. Staff turnover during this period was minimal. Training records show all required certifications were current. An internal compliance checklist completed on September 15 marked all categories as satisfactory. The third death occurred on September 22, 2011. The resident had been observed the previous evening. The log entry reads resident resting. No visible distress. The death was attributed to natural causes. At this point, 3 deaths had occurred within 96 days. Each was processed independently. No consolidated review was initiated. The shift from isolated events to documented awareness occurred in October 2011. During preparation for a scheduled quarterly review, a quality assurance analyst compiled mortality data across state-operated facilities. One facility showed a higher than average number of deaths for the reporting period. The finding was noted as a statistical outlier. A secondary review was requested. The review compared intake assessments, observation logs, and medical summaries. For the first time, entries were viewed collectively rather than individually. The language and internal communications changed. Earlier notes used terms such as appears and may reflect. The review memo used consistent and recurrent. It confirmed that multiple residents exhibited similar low-level indicators prior to death. It confirmed that none of those indicators met escalation thresholds. Under existing policy, the memo concluded that staff actions were compliant. The fourth death occurred 2 weeks later. The secondary review expanded in scope after the fourth death. Senior administrators requested a focused examination of documentation practices at the facility. The directive emphasized process verification, not cause determination. Analysts reviewed 6 months of logs, medication records, dietary reports, and incident summaries. What emerged was not a single failure point. It was a convergence. Across multiple residents, low-level indicators appeared in similar sequences. Sleep disruption followed by reduced intake. Reduced intake followed by delayed medication compliance. Delayed compliance followed by decreased responsiveness. Each indicator in isolation was permissible. Each fell below mandatory reporting thresholds. When viewed together, the sequence was consistent. This observation was recorded in an internal worksheet. It was not included in the final summary. During a recorded conference call, one reviewer stated that the system was not designed to interpret longitudinal patterns without triggering events. No disagreement is noted. A recommendation was made to reinforce existing guidelines rather than revise them. The language used was precise. Clarify documentation expectations. Reiterate escalation criteria. Maintain consistency across facilities. There is no record of discussion regarding system limitations. The fifth death occurred on November 4, 2011. The resident had been classified as medically stable. The previous night's log includes the phrase, "No change from baseline." Emergency responders documented no signs of trauma. The case file was closed within 48 hours. The irreversible decision occurred later that month. A policy update was circulated to all state-operated facilities. The update did not alter escalation thresholds. It did not introduce cumulative risk analysis. It added a clarification. Staff were instructed to continue documenting minor deviations for continuity. The update emphasized that documentation alone did not constitute clinical decline. The system formally acknowledged the presence of signals. It declined to act on their accumulation. This decision required no vote. It required no external approval. It was implemented immediately. The sixth and final death occurred on November 27, 2011. The resident had no acute incident on record. The final log entry states, "Resident resting at last check." Following the sixth death, a comprehensive mortality review was completed. The review confirmed that all required procedures had been followed. No staff negligence was identified. No violations were cited. The facility remained in operation. The findings were archived. The comprehensive mortality review was finalized in January 2012. Its conclusions were administrative. Documentation was complete. Escalation protocols were followed as written. Staff actions aligned with training standards. The review noted that each death, when assessed individually, met criteria for classification as natural or medically expected. No causal linkage was established across cases. The facility's operating license was renewed without condition. In subsequent months, routine audits continued. Inspection reports from 2012 and 2013 described stable operations. Staffing levels remained within requirements. Medication compliance rates met benchmarks. The reporting system remained unchanged. Minor health indicators continued to be logged. They continued to be evaluated in isolation. The internal worksheet identifying sequential patterns was not referenced again. It does not appear in later reviews. It is stored as supporting material, not findings. There is no record of policy revision addressing cumulative low-level decline. Training manuals updated in later years emphasize accuracy and timeliness of entries. They do not instruct staff to interpret patterns beyond defined thresholds. From an institutional perspective, the outcome was resolved. Cases were closed. Reviews were completed. Operations continued. What remains unresolved is procedural. The system recorded the same indicators repeatedly. It acknowledged their presence. It categorized them as insufficient. The records do not indicate error. They indicate consistency. They show a structure designed to respond only when a condition becomes undeniable, not when it becomes probable. There is no documentation addressing whether probability should have been enough. The files end after the final review. No further commentary is included. The facility remains listed as compliant, and in the archive where these records are stored, the sequence appears complete, not because it reached an explanation, but because the system stopped asking questions.